Okay, good morning, everyone. Thank you so much for your patience as we kind of got everything set up this morning. My name is Sydney Carter. I'm the Ready Program Manager at NBHP, and I also run our monthly CEU events. So, welcome to our June CEU event. We have When Aging Affects the Mind with Dr. Garima Arora, and she is in the neuropsychiatry department at Houston Methodist in Sugar Land, and she is the managing director for neuropsychiatry and behavioral consulting, and also a member of UT Health's Consortium on Aging, and a duty representative to the APA Assembly Caucus of Women Psychiatrists. So I'm really looking forward to this presentation today, Aging Affecting the Mind and topics around behavioral health and aging. So please feel free to introduce yourselves in the chat, and I will put in the CEU information in the chat as well. To get 1.5 hours of CEU credit, you need to join by about 10:20 a.m. and stay for the duration, and then take the survey that will be placed in the chat at the end of the event. And then please allow me up to 1 month to distribute the CEUs. I appreciate your patience on that as well. I know if you've been attending our events for a while, I used to be able to get the CEUs out a lot faster, but I have a different job now, so it's taking me a little longer. So I appreciate your time with that. And so without further ado, I will pass it over to our presenter. Thank you all so much.
All right. Good morning. My name is Garima Arora. I have been treating older adults probably for more than a decade now. And I love this patient population, and I'm glad that I'm able to do this kind of a 101. This is a very short impression of what I call geriatric psychiatry 101. We'll be covering a little bit more on the depression, anxiety part of the spectrum, but I will also cover a little bit of the dementia part of things because, that forms a chunk of why people come and see you, whether it be the patient or the caregiver. So let's start. If there are any questions, please hold off till the, end of the talk. You can put some of them in the chat and I will look at them after we're done. And then I will. And if there are any further questions, my email is up there. Just feel free to email me and and I will try to answer your questions to the best of my abilities. All right. Okay, let's see if we can get this. Okay, so what we are going to cover today is the common psychiatric disorders in older adults, the diagnostic stuff that is important for all of us, the treatment approaches, both the psychopharm and the pharmaco and the psychotherapy, which you all are so very adept at. So I'm not going to go in much detail. I'll glance over the ethical legal issues and the current challenges for a little bit. Um, but for the most part, we'll be sticking with the first two, three things, that is the diagnosis, the disorders, diagnosis, and treatment. Um, so, psychiatric disorders in the elderly. The most common ones we talk about are depression, anxiety disorders, including generalized anxiety and phobia. We'll talk about dementia. We'll talk about delirium because that is really important. We'll talk a little bit about the late life psychosis and substance use disorders in the elderly. Again, the last two are not so common but very important in the way we handle treatment approaches. As an overview, depression used to be the most common psychiatry diagnosis in the elderly till like 5 or 10 years ago. But recent data has shown that anxiety disorders are just a tad bit more prevalent now that they are being more diagnosed and more, paid attention to. Um, as you can see, delirium is really common. It is more common in hospital population, but there is a chunk of people, to about 7 to 10% of the patient population, which I call walking delirium or subacute delirium. We'll talk about it when we talk about delirium. And the late life psychosis and substance abuse are anywhere between 3 to 5% of the population, according to research studies. There might be more. All of these numbers, say, are on the lower end of estimation. There are more people with these diagnoses, but they are not diagnosed or not reported as much. Um, as far as as I said, about 10 million people in the US experience any sort of mental illness, and the mental illness increase in the population as the population is aging is going to be a significant increase in the next 5 years by about 4 to 5 million people. 2023 data, as I said, the anxiety disorders have taken over as far as the prevalence rate versus the major depression. Major depression still remains the most common psychiatry diagnosis across all ages, but for the age 65 and over, it's generalized anxiety and anxiety disorders have just a tad bit of a uh, lead. When we talk about depression, um, there's lots of research study. The numbers are very far and wide apart. Uh, in the general community, 1 to 5% of older adults do have depression. It's slightly higher in younger populations, but still about 5% of people over the age of 65 do struggle with depression. And some of it is treatment resistance. So that again becomes very important fact when we are talking about treatment considerations and diagnosis. The rate of depression is higher among people who are hospitalized, maybe because of medical comorbidity, maybe because of the situation they are in, maybe because when they are in a hospital, they're diagnosed better. And again, people who are debilitated or less functioning, like homebound or needing home health care, they are at a higher risk of having depressive symptoms than people who are independent and functioning. About 2.7 million people, according to a recent study, have had a major depressive like episode in the past year, and that is 2.7 million people over the age of 65. Depression in the elderly is often underdiagnosed or misdiagnosed. Now, depression in younger people, and younger meaning anyone less than the age of 65, is doesn't end when someone turns 65. This lifetime of chronic depression again translates to people with depression over the age of 65, but there is also secondary depression or late life depression, as I call it. Late life depression is more related to secondary factors versus a primary diagnosis of depression suddenly coming along at the age of 65. The most common risk factors are medical comorbidities like diabetes, cholesterol, heart disease, stroke, and even medication side effects. The elderly, on an average, take about 5 medications a day. 5 pills a day is the most average number. People can take less, people can take more. I have seen someone take 21 tablets a day for different, high blood pressure, diabetes, cholesterol, uh, blood thinners, things for memory, uh, vitamins, something for acid reflux, something for constipation. It adds up quickly. And so the more medication you take, the more chances of side effects. So we have to, people who are debilitated or weak or frail tend to develop more depression than people who are a little more functional. Um, Loneliness and isolation play a very important role in development of depression in people over the age of 65. This was very evident during the COVID pandemic when rates of depression went up by as much as 30 to 50% in some patient populations. Lifestyle stress, you know, isolation or loneliness secondary to losing a spouse, which is a common issue in people over the age of 65, um, either losing a spouse to death or losing a spouse due to separation or divorce. Both are equally important. There is death is a finality, but it's, like death and taxes are something you cannot escape from. uh, People do not die together mostly, so losing a spouse is very common, and that can lead to the increase in loneliness and isolation. One common issue that I have been seeing is people who are aging 65 and older. Some of these people are what baby boomers and beyond, and these people, some of them decided not to have children by choice. So when they lose a spouse, they lose the only support system or the only part, only regular close tie they have, and that is very impacting and devastating in many ways. Retirement, uh, a lot of people, for a lot of people, going to work is a primary cause of or primary thing that they do in their life. So losing the ability to go to work and feeling rewarded for your efforts uh, makes them feel like a rudderless ship, and that can definitely lead to increase of depressive symptoms, or people who are prone to depression start getting more and more depressed as they retire. Changing in life situations, unfortunately, as people age, their body doesn't is not as strong as it used to be, and people have to move out into independent living facility or assisted living, and changing from three-bedroom house to a one-bedroom condo, about one third or less than that of the size of house they were living in, and living in a neighborhood or community, and suddenly getting themselves replanted into a place with no, like the neighbor they have known for 10 years versus a next door neighbor in an condo complex they have known for 10 days. That's a lot of difference in adaptation, and adapting to a new situation or creating new meaningful relationships gets harder as you age. Um, Another common reason the depression is underdiagnosed is the associated stigma. This generation of people, again, mental health was something that you were supposed to pull yourself up by the bootstraps and get going in life. And depression is only for the weak, especially in the male population. Prevents a lot of them from voicing how they feel or even reporting to their doctors that, you know what, I'm not feeling right. I'm feeling depressed. I'm feeling sad. I'm feeling not wanting to get out of bed, or I'm very fatigued, I'm feeling hopeless, or the feelings of mortality are coming more and more to me. All of these factors, the stigma is real, and the stigma is very powerful in this population and population of people over the age of 65. Depression, again, is not as diagnosed in the elderly because it can present as somatic complaints, worsening or chronic pain that doesn't go away with medications or PT or anything. Worsening fatigue, people think fatigue in aging is not normal. Fatigue in aging, yes, it does have organic causes, but we should not miss out the fact that the fatigue could be related to depression or feelings of inadequacy or low self-worth or not wanting to do things. It can present as irritability, especially in the males. I have seen they become short tempered. Cantankerous old man is, yes, something that we use frequently, but there is a lot of cantankerous old men who are depressed and sad and lonely, and the only way they can express their feelings is not by crying or not by being emotional, but by being irritable, having lost what I call frustration tolerance. And irritability a lot of times is directed at the primary caregiver, usually the spouse. So the patient might not report. Patient might say, oh, she keeps nagging at me, but the nagging of the wife has consistently been the same through their marriage, but suddenly it would be like every little thing irks them, or the wife will say, I have to say the littlest thing. And that is something I'm seeing. A lot of caregivers lose patience. A lot of late life divorces after 25 or 30 or 40 years of marriages could be because of the spouse feeling irritable because they're depressed and unable to voice their feelings. um, Apathy is something we will discuss a little bit further down the road, but apathy is not depression. Apathy is, what's the use? I don't, it's like I can go either way. Decision making difficulties is what it generally comes across. People report they want to sit in front of the TV and not do anything productive. They don't want, it's isolation. So apathy is a different construct than depression and is to be treated differently. Apathy doesn't generally respond to and the common antidepressants. The treatment approach is slightly different to apathy, and apathy is a lot more frequent than depression in people with dementia. We'll talk a little bit about that down when we talk a little bit about dementia. Uh, Using the word dementia, dementia is common, but sometimes cognitive impairments are related to depression. I see more than a handful of people every week who have symptoms very akin to dementia, short term memory loss, word finding, attention issues. Turns out their cognitive impairment are related to untreated depression and anxiety or poorly treated depression and anxiety. One thing I tell my patients frequently, that the most expensive computational equipment that you own is inside your skull. It is completely personalized, and the way it is only for you. But like any computer equipment, it's pre-programmed and it has a bandwidth. Pre-programming means our brain is programmed to prioritize fear over everything else, and the fear pathway and depression anxiety pathways are very similar or overlap a lot. um, Saying that whether that saber tooth in the prehistoric times, whether that saber toothed tiger is going to kill me or the other human is going to kill me, was more important. So weapons came before fire and wheels. And as so pre-programming plays an important role. If you're depressed and anxious, the brain is trying to compute that over everything else, is trying to process that over where you placed your keys, where you parked your car, what is the name of this particular movie actor, or the exact name of that particular brand of apple or particular brand of product, because the bandwidth is there. And if the bandwidth is occupied with you know whether I'm feeling safe or whether I'm feeling centered, then the other concrete tasks take a second stage. So the bandwidth is low, and not just the bandwidth becomes low, the processing speed for these things becomes low. And if you take just these constructs of not being able to do concrete cognitive tasks and the speed of processing being slow, that is almost exactly looks like dementia. So the term pseudo dementia used to be used, but now we use cognitive dysfunction associated with depression, and that's a billing code. So if this is a billing code, means it's often enough. Um, One construct that I do tell people is something called post-stroke depression. Post-stroke depression is common, more commoner than people realize, and the treatment approaches are similar to depression, but uh, a component of apathy does exist there. So we can't just, so we have to, if people have a history of stroke and even TIA, about 30 plus percentage of people with a cerebrovascular incident do develop depression or depressive symptoms or apathy. So we have to pay attention. So if you have a patient who comes to you and is suddenly depressed and they had a stroke, it's not just that the stroke caused the dysfunction and depression, it's the biological construct of post stroke depression that you have to consider when you are providing care. Um, a big reason of worries about diagnosing depression adequately and correctly is that the elderly are a much higher risk rate of suicide. The risk of suicide increases significantly beyond the age of 65. People over the age of 85, especially males, have a 6 times higher rate of suicide than people who are less uh, less of age and don't have depression. And depression by itself causes increased mortality, not just because they are not taking their medicine or they are not taking care of themselves because they are depressed, but depression by itself causes physiological changes in the body, increased blood pressure or blood pressure lability issues, difficulty maintaining sugar control, not just because of medication compliance or compliance with lifestyle changes, but depression as a biological construct by itself. So the morbidity increases. The morbidity of depression is significant in younger population because they cannot go to work and all, but the morbidity of depression in elderly is not just morbidity for the patient but for the caregiver itself. If the patient is depressed, not taking care of themselves, the primary caregiver often has to take off. Or if they try to commit suicide again, or if they're hospitalized, the primary caregiver who has to take off also loses work hours. I mean, it might be the spouse, but children are also a good chunk of primary caregivers. And again, so the mortality and morbidity effect, that also downstream. When we talk about anxiety disorders, we talk about generalized anxiety as well as phobias. One of the common and specific anxieties that I see in the elderly, especially with medical comorbidities and working in the neurology, neuropsychiatry testing, um, neuropsychiatry setting, I see a lot of patients with dementia, including Parkinson's, or including people with, osteoarthritis, knee issues, knee replacement, all of that. And those people, a big major anxiety is fear of falling. So again, gait issues do play a role, and that fear of falling is also something I include in the anxiety disorders. Anxiety disorders can be just plain old, worry warts. What is going to happen with the finances now that I have retired? Can I maintain my lifestyle? What if something happens to me? What if something happens to my primary caregiver? All of that to people who are so anxious that they are almost homebound. Uh, just in last week, I saw two of my patients who are so anxious that they cannot venture outside the house. Cannot venture outside the house is they don't make it to their doctor's appointment in time. It's so hard for them to pick up their own medications from the pharmacy. And, again, that has downstream effects, not just for functioning, but if you are anxious, you can't access your medications, your anxiety worsens. So it becomes a vicious loop. And then if you are anxious, you don't venture outside the house, you become isolated. Again, the vicious loop keeps on adding up. So therapy is very key in those things because medications, as I said, will help reduce the symptom burden, but they won't make you happy. Happiness is a state of mind, and where therapy comes into play. Therapy is the only thing that can help you get to the happiness state of mind. Again, anxiety disorders, just like depressions, are underreported, underdiagnosed, including because of the stigma, especially in males. Isolation and medical comorbidities increase anxiety, rightfully so. Um, and anxiety by itself can cause increased risk of health problems. A lot of people who are above the age of 65 have, because of not just the current lifestyle and the work stress and all of that, are prone to develop diabetes or high blood pressure. And guess what? High blood pressure, lability or response to medication gets altered when people are anxious. Again, a lot of people have heart issues, heart rhythm disturbances. Anxiety worsens things like atrial fibrillation or CHF. And alternative on the reverse side, CHF, cardiac failure, uh, can worsen anxiety. There's a lot of data in people who have three times the level of anxiety if they have a pacemaker implanted versus people who don't have a cardiac failure to the level that they need a pacemaker. And it's normalized to people who have cardiac failure, but people with pacemakers have a higher risk of depression and anxiety than people without. Um, Panic attacks, can't breathe, chest tightening, and all of that. A lot of people end up in the ER because people are like, it's a heart attack, and then they do the $1 million workup and it's not a heart attack. So there's a lot of cost and hospitalization increase because of panic attacks if they're diagnosed and treated early, or if the patient is cognizant that this is what my panic attack looks like, or this situation can make my anxiety go to a level where I feel like I'm having a panic attack, then that can be mitigated by medications, using coping skills to sort of minimize symptoms and then sort of say, okay, it's a panic attack, we don't need to go to the ER. Or a stroke like event, people will become anxious that they will pass out, or they'll start feeling weak. Again, that's not a stroke, that's anxiety. So uh, identifying anxiety and treating it is really important because it again increases risk of hospitalization, and any old person who goes to a hospital has an increased mortality, irregardless of cause. Retirement, losing a spouse, changes in life, situations, all of the major life events do again worsen anxiety, just like they would worsen depression. Now, in the anxiety disorders, I didn't talk about PTSD, but I'm going to approach PTSD just a slight little bit here. Um, Even though PTSD is diagnosed more in younger people, the PTSD in older adults is valid. About 5% of older adults do have frank PTSD, partial of subsyndromal PTSD, not causing to the extent of dysfunction as the diagnosis requires, but meeting some criteria like nightmares or hypervigilance, or you know, uh, kind of anxiety about situations, difficulty talking about their problems, or getting triggered by situations do occur in about more 5.5. So up to 10% of people have some sort of either acute PTSD, chronic PTSD, or subsyndromal PTSD. Sometimes what happens, aging, isolation, bereavement recalls helps them recall their trauma more. Um, Imagine if you have been married for 60 years and your spouse dies in your arms, it's trauma. That helps you recall all the trauma from your loss of your parents, siblings, other loved ones. Trauma recall of isolation, the assault, abuse of sexual or physical or childhood trauma, has been very underreported in this population. So when you are isolated, aging, you're frail, you start feeling weak, and those trauma memories start resurfacing. So trauma is there. It's just that this population of people either swept it under the rug. It was not considered to be trauma. It was considered, okay, forget it, forgive and forget kind of an approach. Forgive and forget doesn't work for PTSD. And so if you have I have, it's surprising to me is then when I start taking history in people with dementia and, or people with cognitive issues or people who have neurological disorders who come to see me, so many people 70, 80, 90-year-old women have told me, I have not told this to anyone, even to my family. But since you asked, I'm going to tell you. There's so much sexual trauma. There is male, female of both variety. There's so much physical trauma. There's so much childhood trauma. So all these memories start, once you're working, you're busy with life, taking care of kids and all, you suppress it. It's easier to suppress, so as to speak. But when you age, you're not going to work. Your life is not as go, go, go. These memories resurface. And when these resurface, they resurface with a vengeance and resurface as anxiety, phobia, distrust, paranoia, hallucinations, delusions, name it, and it happens. Coping strategies, again, as I said, going to work, going to the gym, or self care get impacted when you're older. People are not going, to the gym every day. People are not going dancing as they used to. People are not, their social circle decreases because of losing friends, not just because of, you know, the relationship per se, but people dying, people relocating, as you age, you keep losing friends because they pass on. Everyone doesn't live to be the same age at the same time. So your friends you have had for 60, 70, 80 years suddenly pass on. It makes your coping skill a little less robust. And so that also increases your risk of recalling these trauma memories and developing PTSD. Medical events. Come on, you're sitting there 65 and suddenly you have a heart attack where you feel you're dying, you are in the CCU on ventilator and all. That's a memory. That's not going to go away. That's trauma. And so every time you have a little flicker in your heart, you're like, oh my God, I'm going to have a heart attack. What does that sound like? It's like a PTSD memory, right? So medical events. And it can not just present with the typical PTSD symptoms, but it can present again as somatic pain, heart issues. It can actually present as emotional numbness, that people don't feel happy, people don't feel sad. And again, emotional numbness can be diagnosed as apathy or depression, but if we don't go down to the fact that it is PTSD, we won't address the PTSD. And if you don't address the root PTSD, then you can control the symptoms, but you're never going to achieve a full or good response to medications. Any underlying cognitive disorder, if they have a risk of developing mild cognitive impairment, there will be an increased risk. If they have mild cognitive impairment, the risk of converting to dementia is higher in people with PTSD. PTSD as a risk factor for cognitive disorders imparts 2.8 times the risk, 2 to 3 times the risk of people without PTSD. People with PTSD have a 2 to 3 times increased risk of memory issues than people without. So again, it causes dysfunction to the sense, again, homeward bound. People don't want to leave home because of their PTSD memories. Now let's talk a little bit about one big thing that I see every day. I see at least 20 to 30 people with dementia every single week. So this is something I see quite often. I'm just going to go over what the diagnostic criteria, very short. So the neurocognitive domains we talk a lot about. Some of you might be neuropsychologists or doing cognitive testing. So for you all, this is okay. But for most people, when we talk about cognitive domains, it's not just memory. It's not just immediate memory, recent, long term, very long term, but it is memory, it is attention, not just normal attention, but sustained and divided attention, includes processing speed, executive dysfunction, mental flexibility, differentiating rights or wrongs, doing the same thing. I have a lot of dementia patients who do this. They fold, refold clothes or fold, refold tissues. And when I ask the family members are really surprised. Really? But yes, again, that's a disinhibition part of the executive dysfunction. Long term memory, and memory is not just for events and episodes, but memory is about what, where is the Leaning Tower of Pisa? Where's the Leaning Tower? It's in Pisa. Where is the Eiffel Tower? It's in Paris. So these semantic and autobiographical, or learning about how to use a fork and a spoon, they are also part of learning and memory. Languages, expression, comprehension, word finding, grammar, fluency, all of that. Perceptual motor means visual spatial perception. The most a really common cognitive domain that gets affected in Alzheimer's is the visual spatial perception, and that, again, where you placed your keys is something I people forget. But when you place your keys, you're putting it on the table. It's relative to the table. You didn't put it 6 inches above the ground. You put it on the table next to the uh, phone. So if you forget where the key is, you forgot the visual spatial construct of what a table looks like and what a phone looks like, or where are these things in space and time. And then social cognition is also a big factor in cognitive issues or neurocognitive domains, meaning happy, sad. Many people talk about anosognosia, meaning the inability to identify a particular symptomology, or that they have a particular symptom or disorder. It is the social cognition aspect of neurocognitive domains. So when we talk about minor neurocognitive disorder, or MCI, versus major neurocognitive disorder, which is frank umbrella dementia, can be Alzheimer's, Lewy body, or whatever. So MCI is just a moderate decline and doesn't interfere. You have to be impaired in at least one or more cognitive domains to be called a cognitive disorder per se. But if it does not interfere with your day-to-day living, like you can still drive, you can still go to the bank, you can still take your medications. And I'm talking IADLs. I'm not talking about basic ADLs. Basic, if you are able to do, if you're not able to do basic ADLs, then you have severe dementia by definition. But IADLs, like taking medication, shopping, driving, all of, taking care of the house, cooking, cleaning, if you're able to do all of that, then you have mild cognitive impairment. If any of those are impacted, then you have what we call major neurocognitive disorder, also known as dementia. Numbers wise, 55 million people have dementia in this world, and we are adding at least 10 to 12 million every year, and more so because the diagnosis is getting better with all the new imaging and all the new blood tests and all. 7 million people over the age of 65, and 73% of them are over the age of 75. The risk of cognitive disorders doubles every 5 years, and from the age of 65. So at the age of 65, 2 in 100 people will have dementia. But by the age of 90, 33, one third of the population above the age of 90 has dementia, or has some sort of dementia or cognitive disorder. The projection is by 2050, 139 million. That's a lot of people. I tell most of my patients and caregivers that there is not one person in the world who is in some sort of informative world who doesn't know what dementia is. They have been touched by dementia. Parents, siblings, loved ones, neighbors, relative of a friend, someone in the workplace. Everyone knows what dementia is. And so if there are issues, one of the things, I'm going to go on a little segue out here. The alz.org website has something called Pardon My Companion cards. I tell caregivers to print it out. It's like business cards saying, Pardon my companion. Their behavior is because they have dementia or stroke or whatever. If you hand it out, everyone knows what dementia is. So if your loved one is having a meltdown or crying or getting agitated in the grocery store, just hand these business cards out instead of explaining to people they have dementia. If you're going traveling, hand it to the TSA agent, hand it to the booking person, hand it to the air hostess and say, hey, they have dementia. If things start going sideways, let me handle it, and don't start, everyone not start freaking out pretty much. Dementia at this time is the seventh leading cause of death, and it is one of the major causes of disability and dependency all through the world. They did an estimated global cost of dementia. It was $1.3 trillion. That's not chump change. That's a lot of money. And it's not just manpower hours, but it is actual financial money, actual concrete money issues, hospitalization costs, medication costs. Living in a assisted living facility is not cheap. People's mortgages are not even anything when compared to paying 45,000 to live in an assisted living facility, plus your, normal expenses. So 45,000 is a lot of money. There are places, assisted living places, which are costing 7 to 8,000 to 10,000 a month. That is more than anyone's rent, more than a lot of people's, well, more than most people's mortgages of that age, because a lot of people that age have either paid down their houses or paid off their houses. So again, their mortgages are not as much as their expense of living in an assisted living, where again they're cramped, they're lonely, and all these depression and anxiety are happening. Just as a number, people with over the age of 65, the most common cause of dementia is Alzheimer's, followed by vascular stuff like stroke or small vessel disease. DLB is dementia of Lewy body. FTD is frontotemporal. They are not as common, but they are important. Others like Huntington's disease, alcohol-induced dementia, all of that, they do happen in ages of 65. They are more in ages over 65 than under 65. So Alzheimer's disease, when people talk about dementia, it's not, I tell people dementia is an umbrella construct having, you know, we have 80, 90 different kinds of identified dementia, but Alzheimer's is by far the commonest. Therefore, dementia seems synonymous a lot of times with Alzheimer's. Though the presentation is different, symptomology is different, not just for the cognitive issues, but for what I called BPSDs, behavioral and psychological symptoms, which occur in dementia. Behavioral and psychological symptoms: aggression, agitation, apathy, depression, psychosis, all of that happen in about 90 to 98% of people with dementia. People with dementia will see their psychiatrist or neuropsychiatrist more often than they will see their neurologist. So a lot of times neurologists don't have any more options except for the standard donepezil and memantine. And a lot of neurologists send on people to me saying, okay, I have started these on these medicines. I cannot do anything more for them. What is major concern is their functioning, and what is being impacted by functioning is their behavioral issues, particularly agitation. Agitation is one of the key issues that ends up moving people from an in-home setting to a not in-home setting as dementia progresses. So agitation and psychosis basically, and that's what I treat. That's like I treat almost every day. I see people with that issue. And having said that, there are different kinds of dementia. So different kinds of dementia have different constellations of behavioral and psychological symptoms. Like Lewy body dementia, it is very common to have hallucinations and what we call REM sleep behavior disorder, meaning acting out their dreams. People with Alzheimer's are more at risk for apathy and depression. People with frontotemporal dementia have more apathy, agitation, disinhibition. People with Huntington's have high risks of apathy, depression, and people with Huntington's are 7 times at the risk of suicide as that of a normal of a normal depressed person. Vascular depression presents more as depression, Parkinson's disease, and anxiety. It's significant cause, and Parkinson's disease, some medications can cause gambling disorders as well. So again, people come to me for gambling disorders or sexual disinhibition, and a lot of times it's medications from Parkinson's. We get rid of these medications, we get rid of that, something which is impacting their day-to-day functioning. Depression and dementia, they're very close constructs. As we talked about, apathy and depression seem similar, but where they are two very different animals. Depression can increase the risk of mild cognitive impairment, and definitely it increases the progression of MCI to dementia. MCI to dementia conversion rate over a 5-year period is 30%. So 30% people with MCI will develop dementia, most commonly Alzheimer's after 5 years. But people who have depression develop this transform to about 85% of people with depression, uncontrolled depression. I'm not just saying depression, uncontrolled depression and MCI transform to dementia over a 5-year period. So about 2.5 times. That's a lot of people. MCI makes people functional. dementia, people are non-functional or poorly functional, and that increases the debility, mortality, and morbidity. Um, Delirium, we're going to take a quick look at delirium. Delirium is very interesting, and it is often underdiagnosed, misdiagnosed. Uh, for any consult psychiatrist, this is the bane of their existence. Delirium is basically develops over a short period of time. People are confused, disoriented, hallucinate. People in a hospital, when you see they start running around, kicking, screaming, punching, feeling depressed, not talking, and particularly, it used to be called ICU psychosis. Delirium is a new word for it. It tends to fluctuate. So the patient, the day shift will be like, the patient is such a charmer. He's a perfect patient. And the night shift is like, what are you talking about? This is a cousin of Linda Blair, if I have ever seen one. So it goes from one to the other. And in subacute cases, I have patients who are really well behaved in the morning, but when the primary caregiver comes in the nighttime, it's like they will I have a patient who, while she was delirious, would take a one of those battery lanterns, and while the husband was sleeping one day, tried to bash his head in, or he would try to run out of the house and in freezing cold without any foot protection. So it can fluctuate during the day, and is associated with either cognitive disorientation and language. So it's usually attentional issues plus something else, which is develops suddenly, usually because of a medical insult, and fluctuates. And this is not schizophrenia. One of, again, if you ask one of my consult psychiatrist friends, they are like, I get so many consults from the primary team about, hey, this patient has developed sudden schizophrenia. They were doing well, they are in the hospital, and now they are hallucinating and have delusions. That is not schizophrenia. Schizophrenia doesn't happen overnight. Schizophrenia just doesn't spark out of the blue without any prodromal symptom in someone at the age of 80. And it is usually delirium. Um, and as I said, there is a history, physical or lab finding would be indicative of a medical condition or even substance abuse and withdrawal. Old age people drink. We sometimes forget that they drink, and they drink a lot. Having a couple of mixed drinks at the end of the day, a rum and coke, a vodka tonic at the end of the day is fairly common. Well, not fairly common, but it is often heard of in this patient population. And when suddenly they are in a hospital 3 days and they have not had a lick of alcohol and they are going into withdrawals, they start getting delirious. There are three basic kinds of delirium. One would be the hyperactive, the one we know of, kind of raging, yelling, screaming, disoriented, hallucinational delusions. But on the other side, there's also hypoactive delirium, which is not seen as much and therefore less diagnosed. Is people are apathetic, slow, fatigued, loopy, and not wanting to do things. They don't want to participate with PT. They don't want to talk to nurses. They don't want to take their medicines. And it is delirium, not just, it's not a willful conduct issue. It's not a issue of competency capacity. It's just the fact that they are so delirious, they're hypoactive, their inertia is so much that they don't want to do these things. And then the mix. So again, delirium is underdiagnosed, mixed diagnosed. It causes morbidity because delirium causes people to stay in a hospital longer. It causes a lot of workups. It causes a lot more medication input, and medication input means more side effect profiles. It increases the length of stay in the hospital. Studies have found that mortality in delirium after post-hospital discharge at 1 month, 6 months, 12 months, and even 24 months, 2 years after discharge from a hospital with a delirious episode, the mortality is significantly higher in people who have had delirium versus people who have not. Hypoactive delirium, the reason I stress on it is hypoactive increases the mortality more than hyperactive delirium. It accelerates cognitive decline. So people with any cognitive disorder or at risk for cognitive disorder tend to develop cognitive disorder faster, or if they already have a cognitive disorder, the progression is faster than they were before the delirious episode. And there is a construct called the post delirium dementia. So people have gone with normal cognition, adequate cognition before hospitalization, They come out of the hospital 6 months down the road, they are having dementia symptoms, and this dementia symptoms are akin to having a mild to moderate TBI. A traumatic brain injury causes similar cognitive deficits. So you have to understand delirium is pretty important, and again, higher cost of care for all sorts of reasons. Delirium causes acute changes in. So if there are acute changes in dementia, I have patients whose families, the first visit, I tell them most of the times the trend of dementia is downwards. The with the medications, the symptoms of agitation might remain, you know, controlled dish. But if there's a sudden decline, they become agitated. They start hallucinating in spite of the medicines that they had been stable for 3 months, and suddenly they start getting more disorganized, more disoriented, more hallucinations, wandering, all of that. It is delirium until unless you prove to me otherwise. And out of the delirium, 90 times out of 100, it's a urinary tract infection. Urinary tract infection in the setting of dementia doesn't present as you know uh, fever, chills, or anything. It presents usually as confusion, behavioral issues versus any of that. So I tell people, if there's a sudden change, go to the urgent care or to the primary care, get a urine analysis, and 90 times out of 100, it will be an UTI. So the problem with that is it not just increases the rate of progression, but what happens is people do bounce back, but then bounce back only a little bit, never bounce back to where the original trajectory was. And, you know, repeated UTIs would cause a lot more damage than even a traumatic brain injury. Now we talk about late onset psychosis. Having talked about delirium, I talk about late onset psychosis. Late onset psychosis can be up to about 5% of the population. And as research has shown, it is more in nursing home population and in Alzheimer's patients. Doesn't it sound like a psychology? So the late life psychosis is usually secondary. Delirium and dementia are the most common things that cause late life psychosis. So if you're talking about late onset, very late onset schizophrenia, like psychosis, which is above the age of 75, the risks are 0.1%. So people who have sudden onset hallucinations and delusions, who don't have a cognitive disorder, delirium is the most common key. But people who have a cognitive disorder, it is either worsening of or progression of the dementia, and or superimposed delirium, or and or superimposed any medical issues. Substance use disorders are again very important in this day and age, because again, people who were diagnosed as alcoholics or drugs of addiction are now coming of age where they are in the geriatric population. People who use cannabis in the 70s, now they are in the geriatric population. So cannabis use is get, and they gave up, but the cannabis today is not your grandfather's cannabis. It is more potent. The THC is higher, so the risk of addiction is higher. And the prevalence of this is continuing to increase. There are lifelong addicts, yes, but there's late onset alcoholism because of life stresses. People are alone. And binge drinking and drinking in women has significantly increased over the past couple of decades versus before, because of the aging population. Alcohol is most misused. It used to be other drugs, but cannabis is slowly gaining ground, and it's the second most abused substance in the geriatric population. Prescription drugs also are important. There's intentional misuse. They have pain. They have been told by the doctor to take it up to 6 times a day, so they start taking it 6 times a day. Versus intentional, it's just an addict finding another fix. Benzos are another drugs. Anxiety, as I said, benzos are a double-edged sword. To do or not to do is a very common question I ask. And how much? Again, so that is a treatment consideration we should talk about. We should not forget about nicotine addiction. So cigarette smoking increases the risk of all medical comorbidities, including dementia. So again, we should not forget that nicotine addiction, it's not just smoking. It's not just cigar smoking or cigarette smoking. It's snuff, dip, all of that, and vaping. A lot of older people are vaping. It's not safe. Vaping is more dangerous than smoking in a lot of issues. One side aside is chronic alcoholics and people who have cocaine and all addiction generally do not survive long. So there are less of chronic alcoholics and chronic drug users in this population because they don't live that long. So the lifetime ones are not as much as sometimes people who started drinking or using drugs later in life. Again, Gambling addiction is common. It's not a substance use disorder per se, but it's an addiction disorder. So I do bring it out. And as I said, it could be medication induced versus loneliness and all. And retired people start going to casinos and then they get hooked. So again, gambling addiction, it could be just behavioral or medication induced. Diagnosis wise, a lot of times, as I said, medical illnesses can be depression can mimic these medical illnesses or can be masked by medical illnesses. So depression, hypothyroidism is a known cause of depressive symptoms. So sometimes hypothyroidism is not diagnosed. All hormones and all hormone producing organs start functioning lower and lower. So hypothyroidism is a lot of times not diagnosed and presents as depression. Post stroke depression is again common. Aging population will not report the same classic psychiatric symptoms. They won't say, I'm sad or I'm crying a lot. They will say, my pain is so much worse. I am so tired all the time. I don't want to do things because I'm so tired all the time. I cannot focus, all of these things. And older adults, as we know, do not like to talk about their feelings. Feelings are for the weak. And taking medication for said feelings, forget about it. Well, Prozac is the devil's incarnate in some of these minds. And so, even when they have dementia, they have no decision making capacity. They don't know what they are doing or not. For them, asking them to go on Prozac, why do I need Prozac? I don't need Prozac. I'm not weak. I'm not crazy. I'm not mental. Well, it's not. Craziness is again a construct, a social construct. There's no diagnosis called craziness in the medical world. So being crazy is a very big sin, taboo, a failing, frailty, and people of this generation do not want to accept any frailty. They're very independent, strong minded people. The most important thing in diagnosing any of these psychiatry or neuropsychiatric disorders in the aging population, the key is history. History. I cannot stress enough. Taking adequate history, like the PTSD, if you don't ask, they will not tell. If you don't ask them about clues about depression or anxiety, do you feel worried? Do you feel worried than more worried than you were before? uh, all of these will not come to fruition till you ask them. If you don't ask, they will not tell you. They won't come and volunteer that information. So taking a history, ask not just history from the patient, but asking the people around them, are they gonna, you know, are they behaving the same way? Oh, he has always been irritable. He has always been short tempered, versus he was a gentle person, never raised his voice, and now he is using the profanity like every second, and he's yelling and he's very short tempered. He doesn't have patience with the grandchildren. Using the diagnostic and screening tools like MMSE, MoCA for cognition, geriatric depression scale, PHQ-9 and GAD-7 for depression and anxiety. I don't like PHQ-9 for most of my dementia patients because there is a question about paying attention and moving slow. And that is, if you even answer one, it says you are depressed. So that is not, but geriatric depression scale is a more, uh, for me, a good diagnostic tool. Now there are caregiver tools as well. So I tell people, don't forget to ask caregivers about caregiver burden and stress, because that if a caregiver is stressed out, they will not have the patience to deal with your patient, and that can impact how the patient feels. MoCA, the good part is MoCA is a good tool, especially for people with milder cognitive issues. And MoCA, actually, if you go to the website mocatest.org, they have a training. You have to be certified in MoCA, giving the MoCA test. So the fact that there's a certified training helps learn more. For if you all don't have a, if any of you don't have a psychological testing background, you can go do the MoCA testing. It will give you a more insight into the cognitive level of your patient, even if they have not been diagnosed with dementia, and B, it will help you decide how much are they able to participate in therapy. If they can't pay attention, then you have to make sure when you're giving them cognitive skills that they should be able to pay attention or use attentional tools to help them do better. Psychopharmacology is not an exact science. You don't have any numbers or tools to say, okay, this will work for this patient. All these, you hear of these genetic testing and all, they give an indication of how your body will react to the medication. There's a couple of genes that will predict response to, let's say, the short promoter of the serotonin receptor will predict if you will or will not respond to SSRIs adequately. That means you might need a higher dose of SSRIs. It won't tell you whether it will respond at all or not, or what SSRI it will respond to or not. So all these are there, but they are tools. They would not tell you what medication would work for what patient, because all brains are different and every brain is different on a different day. A medicine which worked for them 2 years ago will stop working for them, start giving them side effect. A medicine which they reacted poorly to, didn't do anything, trazodone didn't put them to sleep, made them stay up all night. Now you give them trazodone 25 milligram, knocks them out for 9 hours. So brains change and every brain is different, so it is a constant course correction for people. We have to consider side effects, whether this is more benefit, sedating people, the sedating aspect of benzo, an increased risk of fall versus controlling the anxiety and issues with the benzo. Again, there we always have to keep talking about it. One thing which is unfortunate in this country is we have to also worry about coverage and cost of these medicines. People who are geriatric are usually on fixed incomes, and whether a drug is $12 or $50 does make a difference in the bottom line of whether they're going to willing and are going to continue taking it as prescribed. The biggest principle I adhere to is the start low and go slow. I'd rather give them less medicine than more, but I don't want to give them, I want to give them enough medicine that will control their symptoms. So, but I don't want to give them any more than necessary. It is essential to continue to carefully monitor for side effects, because these older bodies are more akin to side effects, more akin to metabolic issues, uh, and especially with black box warnings like using antipsychotics in the setting of managing agitation for dementia. I see people more frequently than maybe other psychiatrists. I see people at least once every 3 months to continue prescribing medications like antipsychotics and benzos and sleep aids. Um, Younger population, I might stress it to four, but I like to see people at least once a quarter. I tell my patients the less of me you see is better, but you'll see me at least once every quarter, like in reporting of your income taxes for business. The onset of action for most or some of the medications, especially antidepressants, is 4 to 6 weeks, and the response won't might not be there if the dose is not optimized. So, if a patient was just started on Lexapro, they will not respond. 3 days later, the family is like they are not responding. There's no improvement. Yes, there would be no change in 3 days. It might take up to 6 weeks for to see benefits. So adequate trials are considered at least 6 to 8 weeks of trial of medications at an optimal dosing. So Lexapro doses can be anywhere from 5 to 20. I start people at 2.5, but I tell people let's meet in 6 weeks and see. If not, then 5. If they get to 10 and there's no response, my threshold of stopping medication is it by 10 or 15. If they have not responded to the Lexapro, chances are they will not. And getting to 10 or 15, if you go at this route, is usually 6 to 7 months of a work. So response is slow with antidepressants, some not always. Um, Psychotherapy, all are more adept at it than I am at any time of the day or week. We talk about supportive therapy, coping skills, grief counseling, particularly because bereavement is a big cause of increased risk of depression, apathy, anxiety, all of that, adjustment issues. Don't forget the caregiver and the patient. If the patient is doing poorly, make sure the caregiver is doing adequately to give them the support that is needed and not let the symptoms exacerbate because there is a lot of friction at home. Psychoeducation, not just to the patient, but to the caregivers, telling the caregivers, okay, they are started on medicine, it will take some time to take benefit. You might notice the benefit, but if you're seeing benefit or side effects, sometimes you might notice that before the patient. Behavioral modifications become really important when you're talking about agitation and setting of dementia or patients who cannot participate in therapy. CBT is key for almost all psychiatry disorders, especially the CBT-I, which is the CBT for insomnia. Insomnia is very common in the elderly, not just the sleep onset, but sleep maintenance. So CBT for insomnia is a very good tool to have. CBT for cognition is again a construct. You might want to explore that or get trained if you have people with dementia or caregivers with dementia who are part of your patient population. Definitely make sure your patient is able to participate and remember the coping skills or the homework, because if they are not, then the effort of seeing them one for an hour every week is not going to be as good as it would have if they were cognitively intact. Reminiscent therapy is very common. Music therapy, art therapy, meditation, reading, all of these. Again, cognitive ability of the patient or cognitive reserve of a patient plays a very important role on how they respond to these therapies. Um, okay. Whoa, I went backwards. All right. Another diagnostic consideration for them is symptoms. We did that. Why am I going back? Oh, I'm going backwards. That's my fault. Okay. Then we talk about key strategies in behavioral modifications in dementia. I just wanted to do as an aside and a little bit more detailed in this. Safety is primary. Behavioral modification in dementia, if you're talking to the caregiver, safety is primary. People do get agitated. So keeping a distance, making sure not to push when things are escalating, making sure they're using the medications prescribed as needed for agitation adequately and prudently, but enough to not let the situation get out of hand. The biggest thing is keep calm, make sure it's agitation and not feeling thirsty, not hunger, not needing to go to the bathroom. Pick your battles. Remember, it's not the same person who was there 10 years ago. This is a different person altogether. Triggers and cues are identifiable in some cases. Simple cues. This is what I tell people when you're providing therapy to people with cognitive issues. Make you sure you're making eye contact. Speak slowly. Give small instructions, multi-step instructions. Generally, the brain cannot process as much. As I said, the bandwidth is not there. Yes and no answers. I know open-ended questions and open-ended responses are preferred, but sometimes people with cognitive issues do need a yes and no form of a answer. Do not assume that they are able to comprehend what you're telling them. Make sure they repeat it back make sure they're understanding what you're saying. Adapt their perspective. If they are hallucinating because of Alzheimer's, the hallucinations are as real to them as you are to me. Now, short of me coming where you are and touching you, I don't know whether you're real or not. I'm seeing, my eyes are seeing, but whether you're real or not is something that I can only confirm by touching or having a physical, your presence in front of me. So they are hallucinating, they are as real. So adapt their perspective. Convincing them or trying to logically argument out of a delusion is not happening in people with cognitive disorders. So go with the flow, support and validate their feelings. Confrontations are not good. One of my favorite things, and I should probably register, is something called bluebell time. So if there's escalation of anxiety and agitation, I tell the caregivers, hey, take a break and say, hey, it's bluebell time. Go get a bowl of ice cream. No one feels sad or angry after eating ice cream unless you are lactose intolerant. And that eating ice cream, taking the ice cream, eating a bowl of ice cream gives you the extra 5 or 3 minutes needed for you to, and because you are cognitively intact, for you to analyze whether this is a battle worth fighting. And in a lot of times, people with cognitive disorders would have forgotten by 5 minutes what they were talking about. So they have forgotten, you have realized it's not worth fighting, and everyone is happy. The best outcome. Power of touch, giving them a hug is important. But again, safety is key. If they are ready to punch you in the face, don't try to hug them. If they say, I'm sorry, say, okay, you're sorry, that's it, end of discussion. Do not keep harping on that. And if you need help, ask for it. If someone offers help, take it. Trigger identification is important, keeping them oriented, sensory optimization, making sure their hearing aids are charged, they can hear properly, they can see properly, make them in a familiar environment. Routine and schedule is important. Offer control, but limit choices. Just like I tell people, treat your loved one like you would treat a toddler. Don't ask them, what do you want to eat? Say, do you want to eat a sandwich or a salad? They can make concrete decisions. They cannot abstract it out. So treat them like a toddler. One of the key things, again, side is life skills are learned. Learned life skills go away faster than innate skills. So ability to eat will be there, but toileting is a learned skill. So a lot of times older people will have incontinence or going to the bathroom issues. They can't wipe themselves properly. Increased risk of UTI. Increased risk of UTI means increased risk of delirium, which hastens cognitive diagnosis. So it just keeps building up. Encourage activities. Let them do what they can do for as long as they can do that. If they're wanting to wash dishes, even if the dishes don't get clean and you have to go back and do it again, let them keep washing dishes. environmental safety, positive reinforcement, most importantly, don't leave knives hanging around if they are agitated. You don't want them to be impulsive. Uh, Ethical and legal issues, I just want to give a quick, you all deal with it more than I do, capacity and competency. Capacity is something any physician can assess. Competency is a legal construct that can only be assessed by a judge. So we do capacity assessments, but competency is, again, you have to go to the court to get that done. Make sure the patient, even without cognitive disorders, but if they are over the age of 65, and they know what advanced directives are, they don't know what end of life planning is, they know about a will, they have their financial, medical power of attorneys in place. If they don't need it, they don't need it. But if they do, I call it flood insurance. Hopefully, they will not need it, but if they do, it's already in place and people are not scrambling at the last moment. Elder abuse is very common. And as people in the psychiatric field, we have a duty to report. um, yes, for children, but for elders also, it is the same construct, according to me. I just want to talk about SJAC, Senior Justice Assessment Center. It is, if you look up online, it is something that Harris County has, Harris County APS has. You will have to report it to the APS, but if the APS caseworker, you can say, hey, this is bad enough that can you involve the SJAC people? Look at what SJAC does. They are a really good resource for Harris County. Geriatric psychiatrists like us work with primary care physicians, neurologists, social workers, OT, PT, case managers. I work in a neurology setting. So my office, the way it is, there's a bunch of neurologists, and I'm their in-house psychiatrist. So my only referrals come from the neurologists in the clinic. I see exclusively, almost exclusively, their patients. So I work closely with neurologists. There are not too many people who work in a setting like I do. So this is how I work, and I think that is the perfect place for people with dementia to be, in a setting where neurologists and psychiatrists work together. The biggest challenges in this day and age for this are there are not too many geriatric psychiatrists. There's trying to find a psychiatrist for someone over the age of 65 is hard, not just because they are not specifically geriatrically trained. I'm not a geriatric psychiatrist, I'm a neuropsychiatrist, but by default, because I did my fellowship in cognitive disorders, again, but I'm a geriatric psychiatrist with a twist. But there are not too many geriatric psychiatrists, and even if they are not trained in geriatrics, a lot of psychiatrists are very hesitant to take over people over the age of 65 as patients, because not just because of the complexity of medical treatment, but also, unfortunately, because of coverage. Very few psychiatrists take Medicare because Medicare doesn't pay well. So finding a psychiatrist who takes people over this age of 65 is hard, and someone who understands medical comorbidities is even harder. Not too many consult and liaison psychiatrists, for example, practice in the outpatient setting. They usually practice in an inpatient setting. So finding an outpatient psychiatrist is harder for this patient population, because again, multiple medical conditions, not just the condition itself that can cause side effects, but the medications they take for these conditions. And then there is ageism in mental health care. Again, if you don't ask, they won't tell, because people don't ask. An old person, retired person, is supposed to be happy. They have all the time in the world to relax, but people don't understand that that's what they don't want. Their coping skill was working, now they are not working. Their coping skill is sucky at best, and so they are having these symptoms, and no one is asking them these symptoms, and no one is considering these medicines in these people. uh, Again, they're not considering the right medicine, so they're not considering options. Okay, this medicine has that side effect, so we will not consider it. Like, I've had a lot of, well, not a lot, more than a handful of primary care physicians who will not prescribe an antipsychotic for agitation in patients with dementia. And I have to send them, and I have to sit down and say, hey, I am prescribing that. And they'll be like, no, we don't take it. I will say, take it. And the primary care will say, not take it. And the patient ends up not taking it. The quality of life gets affected. So again, the ageism and medication conditions are really prevalent. So we have to address that as well. And again, the patient population as it is increasing, is aging. The age of our average patient is increasing. And these patients have lifelong mental health issues that have been either that have been well managed in the past but are not well managed now because of changes in body, metabolism, situation, ability to cover drugs, or ability of finding a provider who will prescribe them those medicines. So again, all of this changes and needs to be addressed. And there are NIH and IMH and all have strategic plans. If you go to the HHS website, they do have strategic plans for handling mental health care in the older population. But again, it is a work in progress at best. All right, now comes. All right, any questions for me now?
What questions do we have?
Yes, I will send the PDF to Sydney and she will send it out to you all or make it available to you.
Any questions?
No questions? Wow.
Oh, there is a question in the chat. The UTI specific delirium, is that in both males and females?
Unfortunately, so the rate is higher in females, obviously, because of the shorter urinary tract. But when they forget how to wipe, front to back, it's increases the risk. The immunity is lower because they are, well, not 20 years old. So yes, it is common in both men and women. Men tend to become more aggressive. Women tend to become more anxious, and it's higher in women. But it happens in both. And repeated UTIs. Once you have one, it is kind of becomes more frequently. I have patients who are on preventative antibiotics for that reason as well. Oh, you're very welcome. I'm glad I can talk about it. This is not at all comprehensive. There's so much I can talk about, but condensed version. ALZ.org, the FTLD, frontotemporal lobar FTLD website, FTD website. They have really good data about that might be useful to you all as social workers and um, mental health providers to go take a look at and learn more or find more resources or find more ways to provide help to your patients or for more training.
I have a question.
Yes.
Hi, my name is Letitia Martinez,
Hi,
Oregon.
Letitia.
Uh, if you have a patient that has schizophrenic patient and is taking medicine, but the psychiatrist keeps changing the medication from, let's say, 4.0 to 2.0 to 0.5, and then a couple of months later, he'll increase it to 3.5 again. What can you do about it? You've tried talking
Well,
to the psychiatrist, but he will not do anything. He just
so
keeps.
the thing is, unfortunately, in this population, it is always a constant course correction. That's why even with chronic disorders, I see people once every 3 months because things change and the
Right.
body's response to things change. And people with schizophrenia, unfortunately, the problem is schizophrenia in the elderly has not been studied much because prior to our health system becoming a little bit better for older folk and prior to our knowledge, depth of knowledge about antipsychotics and treatment of schizophrenia, people with schizophrenia, their life expectancy was rarely over the age of 70. So we didn't see so many people with that. I remember once we had talked about dementia when I was early in residency, and the uh, presenter was like, "Yeah, we don't see too many of those because they don't live that long." I mean, it was very blasé to him, but I was like, "Oh my God, that was such a groundbreaking moment for me." But it's a constant course correction, and as I said, I like to give as less medicine as possible, and most psychiatrists will try to keep going down. But if the symptom isn't controlled, then we have to unfortunately go back up. But the guideline with using antipsychotics in the elderly is keep analyzing every 3 to 6 months on the dosage and try to taper down the dosage as every 3 months as you see fit. So you might notice psychiatrists doing that, but again, best thing you can do is psychoeducation of the patient and the family and say, hey, you might want to ask the psychiatrist why. And sometimes what happens is, again, it could be that there's an underlying cognitive disorder and the patient is having hallucinations because of the cognitive disorder, which has not yet been diagnosed. And the patient is agitated and they go to the psychiatrist. Patient is agitated because they have the memory of the schizophrenic or bipolar patient being agitated in a manic state or when they're psychotic. But they have to sort of have a threshold and say, hey, could it be something else other than the baseline disease? And the
Okay.
psychiatrist can then say, okay, see a neurologist, get an MRI and see if it is something else. Because the treatment of something else is different than what their baseline bipolar and schizophrenia diagnosis is. Again, antipsychotics, aging brain responds differently to antipsychotics than the non-aging brain. So again, you have to be course correcting and asking which is better for the patient, the antipsychotic there right now, or there are other newer options on the market which have a less risk of metabolic side effect, which have a lesser risk of tardive issues. So again, keeping medication dosage and changing is common. So talking to the psychiatrist, talking to the family about, okay, you went to the doctor this time. Why did the doctor increase the dose? Why? What symptom did you say? If it's something valid, then you keep track of it and keep talking to the psychiatrist about it. And unfortunately, as I said, not a lot of psychiatrists are comfortable treating the people over the age of 65.
Right.
So their knowledge base or their comfort level of prescribing these medicines is lower as a result. So having a second opinion from a geriatric psychiatrist or a neurologist is not unheard
Okay.
of.
One more thing. Is it
Yes.
normal for a person with schizophrenia to have manic episodes like weekly or?
Again, if there's a cognitive disorder even brewing underlying, yes.
Okay.
A
Okay.
cognitive disorder brewing underlying will cause agitation, which might look like bipolar, or impulsivity, which might look like bipolar manic, that they are drinking more, that they are more impulsive, they are more hypersexual in some ways. It could be medication or it could be an underlying cognitive disorder. People who have been on antipsychotics do end up at a higher risk of Parkinson's. And Parkinson's does come with impulsivity and attentional issues that can manifest as
Okay.
a manic episode.
Thank you. Appreciate it.
So I have a question.
Yes.
For a pretty much healthy elderly person, in addition to her family doctor, would you recommend also to have a geriatric doctor?
So I tell people the primary doctor for most geriatric populations should be a geriatrician,
Okay,
but that's my personal bias.
right.
Because as I said, the family doctor do have exposure to geriatrics, but a geriatrician is more aware of the nuances.
Okay, okay. So any recommendations for?
So UT has a good geriatric division,
So
and a lot of University of Texas Health Science System has a good geriatric. I think U of H Medical School, since they are a newer one, might not have a robust one, but UT has a really robust geriatric division.
where
And you can
UT?
look UT. If you go
Okay,
to UT Health, has a very robust geriatric division.
okay,
They're very active. They are really good clinicians, all of them. I've worked with
okay,
them for a long time. They're really good. If they have a lifelong chronic psychiatry illness, then maybe getting a second opinion from a geriatric psychiatrist or a psychiatrist might not be a bad idea. Again, I see a question here about the SSRIs. So no, uh, people who's I'm going to clarify this. People who are on SSRIs, that is managing their depression, actually have a lower risk of dementia than people whose depression is not managed. Lifelong SSRIs, some of them are neuroprotective, and as an example, there are some antidepressants like Zoloft and citalopram that are prescribed indeed by cardiologists after a heart attack or even after stroke to decrease the risk of stroke, post-stroke depression, which again Depression, unmanaged depression significantly increases the risk of dementia or even any cognitive disorder for that matter.
I have another question.
Yeah.
What would you recommend? And I have many ideas about it, and I put them in practice, but with my mom. So what recommendations would you provide for healthy aging, Dr. Aurora?
Oh my God, that is such a loaded question. So, healthy aging, I tell people physical exercise, mental exercise, maintaining all medical comorbidities, um, and psychiatric comorbidities, diet, lifestyle, all of those are important. Physical exercise is more important than mental exercise, and physical exercise is not mean sitting in the gym for 2 hours. The data is upon 20 to 30 minutes of aerobic or brisk walking is the best, 4 to 5 times a week. And brisk walking doesn't, recent studies have shown that you don't have to do the 30 minutes in one stretch. 30 minutes plus, the more you do, the better it is. But even doing in stretches of 10 minutes, if you do 3 stretches of 10 minutes, has shown more benefit than no physical activity, appreciable benefit. Mental exercise, including being socially active, so being socially active, interactive with people, is very important. Making sure your blood pressure, diabetes, and cholesterol are well controlled. No drug or alcohol issues, preventing falls, making sure your pain is controlled but not overusing medications, addressing substance use issues. All of these are very important. The Mediterranean diet, for example, has shown better cognitive and psychiatric responses, or improving the aging constructs. Cognitively, the only cognitive construct that improves with aging is wisdom. Everything else goes down. After 20, it's all downhill. So, maintaining the cognitive reserve and keeping socially active is very important for that construct.
Mhm.
I
Oh,
see a
thank
question
you.
from Karina about, so I'd rather them take the medication than not, but that's my personal viewpoint. Um, I tell them, hey, if you're drinking, fine. My advice is not to drink. And I'm not taking the joy out of drinking. You're having a glass of wine once, or 2 or 3 times a week is okay, but drinking every day is not a good idea. The motivational interviewing, every visit for alcohol or even drugs is key. But keep taking your psychiatry medicines, because psychiatry medicines only act when you take them. Um, you know, Consistency and compliance is key. So I keep making sure the compliance is there. Again, we can't force them to do anything, but we can advise, and advising them every time is what we can, uh, you know, hope for the best outcome. Getting off alcohol and drugs, again, as I said, I keep reminding them. Keep looking at data. I keep telling them, numbers, data. A lot of times giving them actual numbers about increased risk of, let's say, smoking increasing the risk of cognitive disorders by 3 times. A lot of times patients take note of that. Vaping is worse than smoking. Alcohol use increases the risk not just of cognitive disorders but depression. And alcohol use causes cognitive disorders by itself. I tell people, you use alcohol to pickle things. If you drink so much alcohol, your brain is going to get pickled. You don't want a pickled brain at the old age. You don't want to have cognitive issues. I think cognitive issues and dysfunction with cognitive issues is something that puts a lot of people on high alert. So yes, I will tell them to keep taking the medicine, regardless of whether they're using drugs or alcohol, and keep trying to motivate them to get rid of the alcohol or drugs and maintain compliance. So I think we are almost out of time, Sydney. So my email is right there, garima.arora@npbconsult.com. Feel free to reach out to me. I'm not the most prompt responder, but I do get back to you. So if there's any questions or anything I can help with, just reach out to me and I will try to help as much as I can.
Thank you so much, Dr. Aurora. I learned a lot, and I know a lot of our presenters are sorry, sorry, I shouldn't have tried to talk too fast. I learned a lot, and I know our participants learned a lot as well from the thank yous in the chat and the questions and everything. And so I appreciate your time so much. And I will now go over a few CEU updates. So again, as a reminder, 1.5 credit hours of CEUs available to certain providers listed in the email I sent y'all. And you're eligible if you joined by about 10:20 a.m. today and stayed for the duration, which is now. Take the survey that I just placed in the chat and do that by next Friday, and then allow up to 1 month to receive your certificate. Thank you for your patience. I will send the PDF slides and the recording after this, and I really appreciate y'all's time. Thank you so much. And then as a reminder, also NBHP members are eligible to attend and receive CEUs for free. And if you're not an NBHP member, there's a fee to receive CEU credit. And so that information will be in the thank you email as well that y'all will receive with the payment link. And so thank you all so much again. I really appreciate your time.
Bye, everyone. Have a good weekend. And,
Yes.
just let me know if there's any way I can help, or reach out to me if you need any more information or you need me to do this one more time. All right.
Thank you so
Take care.
much.